Kayembe.
Thank you. Good afternoon to everyone that took time to join us. So let's start with that. What do you think these two pictures are sharing and what differentiates them? This is just besides the color, because they might share the same color, but there are things that differentiate them, and there are also things that are in accord when you see them. So as you can see, knowledge is knowing a tomato is a fruit. So both those pictures contain fruit, but the wisdom is that you should not put a tomato in a fruit salad. So that is just for us to warm up. So we had a very nice talk this morning about dyslipidemia. We acquire a lot of knowledge, but through these two sessions, I think we will try just using that knowledge to acquire more wisdom to how to use it and improve the outcome of our patient. So slicing the tomato today will be just reminding one another and all of us about how significant cardiovascular disease are, discuss a little bit some of the basics about prevention when it comes to CVD, and we will visit the issue about risk assessment, tests that need to be ordered, why and how, and which strategies that we have at hand when we need to prevent cardiovascular disease. So why is it significant? Cardiovascular disease is the leading cause of death globally. We need to remember this. We care about HIV, we care about TB, we know that we need to report on all those things. We know that we need to do our best when we deal with HIV patient or TB patient, but let us not forget that cardiovascular disease kills 10 times, no, even 17 times of more people than HIV when you check the statistic. And this is basically 1 in 3 people that die in the world or that died in 2019 died because of a cardiovascular disease. And 3 in 4 of those patients that are dying for cardiovascular disease are our patients. And 85% of those deaths are caused by heart attack and stroke. And we know that heart attack and stroke are mostly, the majority of these deaths of this condition will be related to atherosclerotic vascular disease. And that's why the dyslipidemia and the statin and all those lifestyle modification or adjustment comes into play. And so we cannot argue on the fact that the key initiating event in having atherogenesis is the retention of LDL cholesterol. That's why, again, you cannot, if you want to take care of this patient, you cannot limit yourself by only assessing your patient cholesterol or using just your patient cholesterol as your surrogate for LDL. So ideally, whenever we deal with this patient, if we want to prevent cardiovascular disease, if we want to reduce mortality, if we want to reduce morbidity, if we want to reduce disability related to cardiovascular disease, we need to go to the root of the problem and address the key event that will lead to atherogenesis. So, talking about prevention of atherosclerotic vascular disease, we cannot also argue on the fact that at the general population, we need to promote healthy lifestyle. We need to promote healthy life behavior. But we also know that usually by the time you want to start teaching your patient, you are already having a patient that is obese. By the time that you want to teach that patient, it is a patient that already got a stroke or a patient that got angina already. So yes, we should teach the patient, but from time to time, and some of them have been born with this condition. They've been, if you deal with a patient with familial hypercholesterolemia, you don't have any choice. Yes, you can tell them to eat properly, but the body will still induce and produce bad cholesterol that will end up increase that patient cardiovascular disease. So, and we know and we remember that yes, the boat would have left. It will be already sailing on LDL, it will be sailing on uncontrolled diabetes, it will be sailing on uncontrolled hypertension. That's why whenever we are faced with taking care, with the responsibility of taking care of this patient and having in mind that we need to reduce mortality, we must be able to assess the risk for cardiovascular disease. So these are some of the tools that we have and that you can read when you take a paper from South Africa. It's not scope, it should be spell score system. And and there is a South African Act, which are tools to assess risk. But we know that in South Africa, based on the fact that Framingham has been validated in both white and black population in America, it is one of the tools that is recommended for us to use when we deal with our patient in South Africa. The only time that they say you should refer to the SA art is when you are in research and you are dealing with funders that are from South Africa. So, and when you go and assess your patient cardiovascular risk, we need to remember that this risk will be, either your patient will be very high risk or high risk or moderate risk or low risk. We need to be able to assess and document that. And this high risk, it is meaning that your patient will be, your patient risk will be greater than 30 when it is very high risk, between 15 and 30 when it is high risk, less than 15, but above 3 or equal 3 when it is moderate risk, and low risk when it is less than 3%. And you will have to enter some data in the scoring or the Framingham scoring system or table for you to determine your patient 10-year cardiovascular risk for coronary heart disease, stroke, peripheral arterial disease, or heart failure. So this is just to remember which data do we need whenever we want to calculate, because this is the tool that we should be proficient with and be knowledgeable about it, is that we need your patient age and gender. We need the patient total cholesterol. We need the patient HDL cholesterol. We need your patient systolic blood pressure. And you need also to remember, it's not only to take the blood pressure in isolation. You need to compute the fact that the patient is on treatment or not on treatment. And you need your patient smoking status. Is your patient smoker or not? So this is just a typical patient. This is a patient in Ward 5 that is male, born in 1970, with a blood pressure of 145/90, who is on dual therapy. He is also HIV on a second line ritonavir boosted PI. He is a smoker, and his total cholesterol is 6.42, and HDL is 1.37. So all that we need is that, remembering those things. No, it was not a smoker, it is a non-smoker. So you go through the table. For his age, you will score 8. For his cholesterol level, you will score 3. For his HDL cholesterol, you will get -1. But the blood pressure give him extra 4. So your patient total score, and you take the total score for male patient 14, you use the chart for the cardiovascular disease risk 10-year, and when a patient score 14 and this patient is a male, that corresponds to a cardiovascular risk of 18%, which means that your patient has a cardiovascular risk that is high. So that is how we need to apply or to use this tool. So remember, you need all those 4 elements for you to 5, 1, 2, 1, 2, 3, 4, 5, 6 elements for you to determine your patient cardiovascular risk. So now that we know that we should calculate, we should also remember that not every single patient needs the calculator for you to make up your mind on his cardio or her cardiovascular risk. And this is particular for patients that are known to be at very high risk or high risk of cardiovascular event. Those patients, the calculator will usually underestimate the risk. So it is not recommended to run them through the calculator, but rather remember the list of these situation where the patient is at a very high risk. So a patient with established atherosclerotic vascular disease, meaning a patient that had a stroke before, a patient that is known to have had a TIA, a patient that has that had ACS, a patient that have a chronic coronary syndrome, a patient that has a peripheral arterial disease, that patient has established atherosclerotic vascular disease, you don't need to run a calculator. You just need to remember that that patient is very high risk, meaning the risk for cardiovascular event is greater than 30%. Every single patient with type 2 diabetes, these the recommendation of the categories as defined in the South African document. A patient with type 2 diabetes with one or more other risk factor, meaning smoking, hypertension, or dyslipidemia, or a patient with diabetes that is 40 years older should be considered to be at very high risk. A patient with type 1 diabetes with microalbuminuria or proteinuria should also be considered to be at very high risk. Don't waste your time calculating. And the patient with genetic dyslipidemia also will be automatically considered to be at very high risk. Same apply to every single patient with a eGFR of less than 30, automatically they should be considered to be very high risk. High risk, there will be patient with uncomplicated type 1 diabetes and patient with type 2 diabetes without other risk factors. So if they are type 2 diabetes and they are not smoking and all don't have hypertension and all don't have dyslipidemia, those patients will be considered to be only high risk. It means between 15 and 30%. And when eGFR is less than 60 but greater than 30, your patient with that CKD will be considered to have high risk. But there is also high risk when your patient has a single risk factor that is very, very, very elevated. In the South African document, you will only find the grade 3 hypertension. So every single patient that comes to us, and these are the patients that we usually want to give amlodipine, we should not only be focusing giving them that 10 milligram of amlodipine, but documenting that they are high risk when it comes to cardiovascular disease risk or cardiovascular event risk. So in the South African document, you will only see grade 3 hypertension, but when you read international papers, they also consider every single patient with a total cholesterol of greater than 8 to be high risk. Just that single risk factor put your patient, in the absence of everything that we've spoken, every single patient that comes with total cholesterol of greater than 8 should be considered to be high risk. And when you zoom into the lipogram and you find that your patient has a LDL of greater than 4.9, even in the absence of any other risk factor, that patient should be considered to be at high risk. And whenever you initiate starting or you start planning to discuss cardiovascular disease prevention, you need to have that in mind. Those are the two conditions or situations that are not covered in the South African document, but you can find them in the ESC document from 2019. So again, when you go to the current recommendation internationally and you go back and compare with what the South African document highlight, you see they're talking only about risk factors, but they don't really compute for the target organ damage. So every single patient with type 2 diabetes that has target organ damage, and how many of them do we have that might not have the cholesterol that we expect, or that might not have many other risk factors that we've discussed, but that have peripheral neuropathy? That patient is a very high risk. So you need to retune the patient assessment, because we will tend, when we use the South African document, to put them into high risk only, while they should be treated as a very high risk. Same apply again, just to refine. And I think people that have the document from Ampath lab, or when you go to the website, you might see some conflicting categories when you compare with what you find in the consensus guideline, the South African consensus guideline for dyslipidemia. Is that we need to remember that whenever you have type 2 diabetes without target organ damage, but the duration is equal or greater than 10 years, that patient should be considered to be high risk. Or if the patient have just one additional risk factor, that patient should be considered to be high risk. So those are some of the things that we need to now learn, and whenever we go back and deal with our patient assessment or adjustment of treatment, or even just assessing that they are on target or not, we might need to change the treatment management plan. So now, this was one of the issue that was brought up this morning. So we measure lipid because we need lipid to assess the patient's cardiovascular risk. We need the lipid because we know that the key determinant event is how much LDL our patient would have been exposed to. But the issue here is we also know our patient, whenever they come to the hospital and they need to be fasting, or they think that they should be fasting, it means they want to take medication. So now, do you need your patient always to be in the fasting status for you to take blood for lipid or not? So traditionally, it has always been that way. But the beauty of life is that things change. So currently, it is known that there is almost no difference between lipid parameters that have been determined in a fasting state and in a non-fasting state. There are systematic studies that are there to back up this statement. So, and if you read the guideline over the world now, including the South African guideline, it is recommended that we do non-fasting sampling for our patient. And whenever you do it, all that you need to remember is that that difference will usually apply to triglyceride, and it will be around 0.3, meaning it is not significant, but the implication is that you can only flag your patient triglyceride as being abnormal if triglyceride is 2.0 or more, not 1.7, which is the upper limit of normal at the lab, because you've taken blood in a non-fasting state, and it is understood that the meal could have pushed triglyceride by about 0.3. And so those are things that we need to remember. And so abnormal triglyceride in non-fasting state is not 1.7, but equal or greater than 2. The only time that you need to ask your patient to go fast and come back is when in a non-fasting state, the triglyceride is reported to be greater than 5. So we had a discussion this morning. I hope now things are clear. There is no discussion about it can be done, should not be done, every recommendation about what will be the implication of taking blood in the fasting, non-fasting state is there. So don't ask your patient, or don't ask your patient to go back just because they told you they got angry and they ate, and they need to go back and pay money to come back again for another sampling. So there is no difference. And the recommendation, again, even in the South African document, this is a statement lifted from the South African guideline, is that it makes life easier for your patient, it improves compliance or adherence, and it is easy. It will be one visit and you do everything. And you can use it to screen your patient. You can use it to assess your patient risk. You can use it to diagnose your patient, and you can use the non-fasting lipogram to monitor your patient response to treatment. This is from the European guideline. Again, it is practical that it is done on non-fasting sample. So a patient that have eaten should not be sent home just because they've eaten, unless the previous triglyceride in a fasting state was greater than 5. So we also discussed this issue, or that it was brought up again. We need to remember, we take this blood, we need total cholesterol, we need HDL, we need LDL, because we need to know what is the baseline. But we need also to be mindful that we can take the blood, but still not receive a report about LDL. And when should you not panic? It is like when you order a gene expert and they give you a trace report, you know that you cannot get rifampicin sensitivity report. So we also need to know that whenever we pull blood for LDL or for cholesterol, for lipogram, we might not receive the LDL cholesterol report. When we don't receive it, we don't receive it when our patient triglyceride are greater than 4.5. Why we cannot receive it? We cannot receive it because it is estimated or calculated but not measured. Unless you are in private, until the day the government has enough money to measure directly, we need to be mindful and not pull blood and send again, hoping to get LDL reported. It won't be reported because for it to be calculated, triglyceride should be less than 4.5. And the equation that is used is the equation in front of you. The LDL is calculated from the total cholesterol equal minus HDL minus triglyceride, that is divided by 2.2 when it is expressed in millimole per liter. So let us be aware of this. LDL can go missing. All that we need to check was triglyceride greater than 4.5. If it is the case, you know that you will be flying blind. You need to treat without knowing what is your patient LDL. So should we be worried that maybe the measured is better than the calculated or the estimated? Not at all. There is a very strong correlation. That's why the government, to save money, rely on estimating the LDL, because it's not that different from the one that is measured. So what is the panel of lipids or lipoprotein made of? It will be the total cholesterol, the HDL cholesterol, the LDL cholesterol, and the triglyceride. This is the screening one, because later on when you monitor, unless triglyceride was elevated, ideally for monitoring, you will only be ordering LDL. But unfortunately, in our case, because LDL is not measured, it means even for monitoring, you will carry on ordering both total HDL and triglyceride, because in our setting, in government setting, you cannot get LDL without ordering the full lipogram, which is total cholesterol, HDL, and triglyceride. So why do we need the total cholesterol and the HDL? Remember, in the Framingham, you need these two for you to get your patient risk, cardiovascular risk when it does apply. When do you need the LDL and why do you need the LDL? It's for you to know your baseline, and from knowing your baseline, and choosing, now that you know the risk, you know the target, you will know how much reduction is needed for you to prescribe the correct treatment or to choose the correct treatment for your patient. Why do you need triglyceride? I will just insist again and go back to the fact that triglyceride is needed for us to calculate, mainly for us to calculate LDL in our setting. So now we go back again to one of the topics that we had to discuss this morning. We know the risk, we know how significant cardiovascular disease are when it comes to mortality, morbidity, and even disability in the world. We've assessed our patient, we've pulled the blood, we need to decide to start treating our patient or to manage our patient to try to mitigate the risk. What are those intervention strategies that we have when considering cardiovascular prevention? So we need to keep in mind, are we dealing with primary or are we dealing with secondary prevention? Again, it's just for us to remember that no one should come and say that statin should always be under lifestyles. Lifestyle is a cover, yes, but statin might be the primary intervention in some patients. This is just to give you an idea. As you can see, the green is when lifestyle applies alone, but you only have greens mainly in primary prevention, not in secondary prevention. As you can see, in secondary prevention, there is not even a green. You start with a yellow and almost 1, 2, 3, 4, 5, 6. You have 5 out of 6 that are primarily depending on statin to be started as soon as possible, concurrently with lifestyle intervention. It's only when you are in primary prevention that it's even less, but we can just round to say half of the situation where you might consider to give or to rely on a lifestyle only. But even in primary prevention, depending on how high your patient lipids are and how high your patient's cardiovascular risk is, there are also instances where you should start concurrently lifestyle and statin. Just visiting the lifestyle changes and the impact on the lipid, the magnitude of effect will be, for those measures that are very, very effective, is that they can only reduce by 10% or more. There is, and which measures are the most effective? Those measures that score 3 pluses, it is reducing alcohol intake and increase physical activity. All other measures will only impact on cholesterol, will reduce it by less than 10%. 2 plus, it is between 5 and 10%, and 1 plus, it is just less than 10%. So having those measures in place might assist you in not needing a lot of statin, but there are situations where they will never replace statin. And if we talk about, if we think of 10%, you will see that almost every, that is the reason why in secondary prophylaxis, which is mainly in patients with very high risk that need high intensity statin, you will never offer lifestyle modification alone, because every single lifestyle change will not even beat 10 milligram of statin. So this is just to remind one another about the intensity of statin, as we will be prescribing statin and monitoring statin next week, is that whenever we prescribe, we need to know how much lipids or cholesterol will be decreased by how much statin that we prescribe, based on how far or close are we to the target. So simvastatin 10% can only reduce less than 30%. If you want to reduce more than 30%, but less than 50%, you will start with 10, but you need as soon as possible to increase to 20 to 40 milligram of simvastatin, or move your patient to 10 to 20 milligram of atorvastatin. I just use the statin that we have access to. I didn't want to put the one that we cannot afford. And whenever we need more, 50% or more of LDL to be reduced, simvastatin is peanut. Atorvastatin 20% is not enough. Your patient will need 40 to 80%, 40 to 80 milligram. So it is simvastatin 10 milligram, atorvastatin, it is in milligram, not in percent, and atorvastatin 40 to 80%, 40 to 80 milligram if you want to reduce 50% or more of your patient LDL. So next time we will be discussing how significant statin are, how do we initiate statin, what are our patients, what will be our patient target, how do we monitor our patient, what are the side effects that we need to be mindful of, what are the contraindications for statin, and what are the significant drug-to-drug interaction that we need to be mindful of. Thank you very much for your time. I hope that we have now data, things that are written down that are not depending on me or depending on anybody else. The references are there. So everything that we've discussed, you can honor them going forward and back your choice and practices when you manage patients with cardiovascular disease. Thank you very much.
Thank you very much, Dr. Kayembe. Excellent start. I'm very happy to see we've got some medical students on the call as well. This is sort of the bread and butter of family medicine, is looking after our cardiovascular patients, and dyslipidemia and prevention, a huge part of that. I would like to open the floor. If there's any questions, you can either put questions in the chat, or you can put up your hand, or you can just unmute yourself. If you've got any questions about today's presentation, we are going to continue on this topic next week. Nothing specific at the moment. Dr. Kamangele, sorry, just confirm again for the group that's here at the moment, whether it's next week, Wednesday or Thursday?
Wednesday will work for me.
Okay, you're also happy with Wednesday. So okay, great. I'll move the date on that to Wednesday, and I will send out the links again for continuing on this session. And we will make the recordings available both as video and as podcast to please circulate to those people who did not make it tonight. Does not look as if there's any burning questions at the moment. Dr. Kabengele is always very thorough. And we look forward to continuing the topic next week. Thank you very much, Doc, for making time and spending so much effort on your post-call day on these beautiful slides.
No problem. It was a duty that we owe all of us.
Thank you very much, everybody. Have a lovely evening, and we'll see you next week.
Bye.